My name is John Pandolfino, and I'm the current president of the American Neurogastroenterology Motility Society. And it's really my pleasure to welcome you tonight to our ANMS virtual symposium. Now, before we start, I certainly want to remind everybody about our meeting at the Fairmont Austin in Austin, Texas, on August 11th through the 13th. This will be our combined clinical and scientific meeting. So really looking forward to this very different venue. We haven't been to Austin before, so pretty excited. Also want to make sure that people remember that we have the esophageal, gastric, colonic, and anorectal motility procedures workshop. That's Saturday, February 25th, 2023, and that'll be full day 8 a.m. to 4 p.m. And then last but not least, I also want to make people remember about all the deadlines that we have for all of our grant submissions and so forth. I know you saw the PowerPoint flashing ahead, but certainly we're looking forward to a very comprehensive and integrated and involved meeting in Austin. So looking forward to it. So without further ado, I'm going to start our process here by bringing in and introducing our moderators tonight for the symposia titled Medical Procedure Education Series, Pearls of Wisdom, focused on colon manometry. Our two moderators tonight are Jason Baker and Lusine Ambartsumyan, both very well known in this field. Jason, as many of you know, has been a real great advocate for the people who are performing this procedure, our allied health professionals who are really at the core of doing these difficult, very complicated procedures. And Lusine is a star in the world of gastroenterology and in particular motility. She works at the Seattle Children's Hospital. Her clinical and research interests include mechanisms of fecal incontinence in children with functional and organic defecation disorders, specifically focused on patients with these complicated anorectal malformations, neurogenic bowel. So it's really my pleasure to hand this over to them tonight so that they can introduce our invited speaker. Thank you.
Thank you, Dr. Pandolfino, for the kind introduction. I'd like to thank Dr. Ambartsumyan, co-moderating with me tonight. And this is going to be really about pearls of wisdom from a colon manometry standpoint. Our guest speaker is Lisa Sitz, and Dr. Ambartsumyan is going to introduce Lisa. And then after we do the introduction, Lisa will present for us. And if there's any, for all questions, if you could put down the questions in the Q&A little icon on the bottom of the screen, and we'll field them after the presentation. Try to get through as many as possible.
Thank you, Dr. Baker, and thank you, Dr. Pandolfino. Thank you, ANMS, for having us today. It is my absolute pleasure to introduce Lisa Sitz. She's a pediatric nurse practitioner for the Neurogastroenterology and Motility program at Children's Healthcare of Atlanta. She completed her undergraduate at the University of Georgia and obtained her nursing degree from Medical College of Georgia, now called Augusta University. She fell in love with children and pediatrics, and specifically gastroenterology. She obtained her degree in pediatric nurse practitioner in 2016 from UAB. She's also the recipient of the prestigious DAISY Award, and her specific interests are functional abdominal pain, constipation, and rumination. Thank you, Lisa Sitz, for being here today and for presenting.
Thank you very much, Dr. Ambartsumyan. That was a great little intro, and I appreciate it. Thank you guys very much for giving me the opportunity to present tonight. I know this is a very busy time of year, so taking the time, whether it's now or in the future, if you have some free time just to look through this presentation, I would really appreciate it. And without further ado, we can go ahead and get started. So I'm just going to share my screen here. Okay. So pearls of wisdom, a colonic manometry. So no disclosures. And I wanted to give a little bit of background. Obviously, I'm going to have to give a shout out to my Georgia Bulldogs for all of their hard work this season and being a fellow UGA undergraduate. But that's kind of where I got my start. And then was able to be fortunate enough to kind of find my career path at Children's Healthcare of Atlanta. it's exciting when I talked to Jason about the whole process of the pearls of wisdom. I think it's really cool because we all have our individual backgrounds and different skill set that really helps us as clinicians become better for various different reasons. And being able to share our own personal pearls of wisdom and kind of what we've learned through the years, I think is important, because most people can learn protocols, and learn the process of various different testing, but being able to speak to it to a level of really understanding it from the patient perspective and as clinicians being able to share ideas, I think is just really cool. So I've worked with the Neurogastro and Motility program at CHOA since 2016. We are able to do anorectal, esophageal, intraduodenal, and colonic manometry at CHOA. Our program has been in place for several years and continues to grow, and so we're really excited to be able to provide this service for the children in the Southeast. So we'll start just with some kind of colon 101 basics, got to start somewhere. So the colon is responsible primarily for the absorption of water, electrolytes, producing and absorbing vitamins, forming and propelling feces towards the rectum for eventual elimination. This is all in part done by peristalsis, which can occur in response to luminal distension and is primarily controlled by the enteric nervous network. The lovely interstitial cells of Cajal, which are the kind of pace car, are very important in this process, specifically the interstitial cells of Cajal and the submucosa within the proximal colon. These are mechanosensitive. So basically, they're able to turn a stretch stimulus into an electrical activity kind of potential. So this initiates peristalsis in the proximal colon, and then that's able to be propagated in an antegrade fashion, which helps us eventually eliminate stool. I like to think of this when I'm explaining this process to families that it's kind of like the wave at a baseball game. So that initial wave starts in one section, which for us is the proximal colon, and then it's got to be nicely propagated throughout, the entire length of the colon. So sometimes giving the families that visual is really helpful. So colonic manometry. What is colonic manometry? So it evaluates the intraluminal pressure and the coordination of the colon. This is the one motility study that's actually done more commonly in the pediatric setting, which is interesting. We do these weekly typically, and is definitely one of the most common that we see in our motility clinic. So why would we do colonic manometry on a patient? This could be related to refractory constipation. So if we're trying to evaluate whether this is either a functional or a motor disorder, colonic manometry is key for getting that objective data so that you really know how to move forward in treating that patient. It helps you evaluate the need for surgical intervention and or evaluate for post-op progress. A lot of times we have patients who potentially had an incredibly dilated colon or rectum, and at one point had a diverting ileostomy, and the physician or the surgeon may be questioning whether or not this patient has had a long enough time to allow for rectal decompression or colonic decompression. Is it okay to maybe think about reconnection? So this can be really useful in guiding that future surgical intervention, which we'll also talk about a little bit later in the presentation. Abnormal transit study. So if a patient has, through their workup, had an indication like a Sitz marker study, which is no relation to me. It's very interesting that my last name is Sitz, but I promise I have no affiliation with Sitz, the makers of the Sitz marker. But if a patient has an abnormal transit study, then it's definitely worth evaluating further with colonic manometry. And then we also, we kind of call it waiting on the magic unicorn poop, or the chronic belly acher. So these are patients where they've typically had a pretty significant workup, and while the degree of their constipation may not be very terrible or may not be on the extreme side, they've really focused on the fact that a lot of their abdominal pain is related to constipation for one reason or another. And so sometimes, again, getting that objective data is just really helpful in guiding the future care for those kiddos. So constipation. This is the most common thing that we see, or most common complaint that eventually ultimately leads to patients getting colonic manometry. This accounts for about 25% of pediatric GI consultations, so it's a significant number. And the most common reason, of course, for performing colonic manometry in pediatrics. Most often, especially in pediatrics, and I kind of speak to that just because that's my sort of wheelhouse, most often it's functional in nature, but it can be very difficult to treat, especially in the setting of constipation and fecal soiling. And given that situation, and knowing about 1/3 of patients continue to have chronic symptoms despite laxative or behavioral medication, it's really important from the general GI perspective to think about early referrals for those kids, especially if they're starting to have soiling and they're just not getting, progressing with laxative therapy or behavioral interventions such as sitting, good toilet behaviors. Important to make those referrals for motility evaluation so that we can try to limit the chronicity of complaint, which then leads to further colonic and rectal distension and just ultimately becomes much more difficult to treat over time. So history is really key. We always see our patients, of course, first in clinic before we admit them for colonic manometry to understand the primary symptom and not just the complaint. So is it that patients are having infrequent stools and they feel like they're constipated? Is it that they have a feeling of incomplete evacuation? Do they have belly pain additional to their complaints of infrequent stooling patterns? And that's something that we need to address as well. This is also important in the history to determine the need for anorectal manometry. I think of anorectal manometry as like the sister or younger sister of colonic manometry, not so much in a negative way, but it's a fairly easy test to do that can give you a lot of information, and especially coupled with colonic manometry, it just really allows you to be able to understand the entirety of the issue. Is this a colonic dysmotility process? Is this a patient that's withholding? Do they have dysenergia? So making sure you couple those together is really helpful. Compliance in previous regimens. We hear it all the time. We've tried all the things and nothing's working, and this is why we need to have this test done. So understanding what level of compliance patients really have had in their previous workup to understand and kind of start building the clinical picture. Like, is this true medication failure, or is this potentially non-compliance? Those kind of things. Looking through the past workup is important as well. So I like to talk through the workup that's been done prior to patients going into colonic manometry, because most of our patients have had quite extensive testing that's done before we just jump into colonic manometry. So it's really valuable for the family to understand, the patient to understand, this is what we've seen on your previous testing, and so here's why we think the result may show this, or here's why we think this may be normal, and setting that kind of stage prior to going into the testing so that everybody's on the same page and you have realistic expectations. Especially important on transit studies is understanding where the radiopaque markers are. So if they're scattered throughout the colon, then that's usually an indication that you're probably going to see something abnormal on the colonic manometry. If all of your markers are sitting right there in the rectum, then most likely a patient that potentially has like a functional retentive constipation, and talking through that and helping the family understand what that means and what may or may not be seen on colonic manometry. And then also to set realistic expectations in regards to what the study will show, potential outcomes, discuss it at both the family and in peds, of course, at the patient level. So the equipment that we use, we're fortunate at CHOA to have solid state catheters. We use solid state high resolution catheters, have 36 sensors. It's kind of a one size fits all deal, so we don't have various sizes for depending on the size of the patient. These are great because the tracing is viewable in real time as a topography plot. So that visual is really nice, not just for me when I'm going through the process of the test, but we can explain it to the parents or patients in a way that sometimes it's easy for them to grasp. Water versus solid state. So we find that with solid state, it just stays put better. So we don't end up using a clip when we go to actually place the manometry catheter. And then also with solid state, there's a little bit less artifact. So this is particularly helpful in young patients that are mobile and do their best to try to kind of stay in the bed while, you know, in that sort of post-catheter placement timeframe before you actually start the study. So it's helpful for us having the solid state catheters. So prep and placement. So our process is we admit patients, we have kind of a 3-day process. So we admit the patient on, we call it clean out day. So often with this, we usually do an initial KUB to assess the stool burden. So that way, as I'm ordering the clean out, I kind of know what I'm up against. Sometimes it's very basic, which would be like a nasogastric tube that's placed that we then infuse clean out solution like New Lightly. We typically run that until a patient has clear stools. Lots of times we end up needing to be a little bit more aggressive, again, because these are typically like the worst of the worst constipators that are coming in for this study. So for those kids, we do at a minimum Dulcolax suppository, and I explain it to parents like, yes, it's not ideal to do things rectally, but it's kind of like pulling the plug out. So you pull the plug and then typically the infusion from above ends up going a little bit easier. Then other times we move a step forward, and that's when we do high volume normal saline enemas. And that's really in our kids who we're really struggling to get them clear. We've got a time crunch where we have to be nothing by mouth after a certain point in time to be able to do the endoscopy portion of the colonoscopy. And so at that point, we do high volume enemas. Important to order if you're in pediatrics, child life consult for that. The following day after the clean out is complete, we then take patients to our GI procedures lab. And our catheters we place under general anesthesia via colonoscopy with fluoroscopy guidance. And then we kind of secure it. Like I said earlier, we don't clip anything just because we found that the solid state catheter stays put pretty well. We use the wire technique with fluoro guidance. And I feel like in my years of being with the team, these typically go pretty well. Usually the most difficult time where the placement does not go well is if the prep is not complete. So I do my best to really make sure that patients are having like completely see-through stools by the time the prep is complete. Because the last thing you want to do is put a kid or any patient through the whole prep and then it not be complete, go in to do your colonoscopy, and then you can't see anything and you have to pull the whole thing because it's not, you know, appropriate to just kind of thread the catheter in blindly. So good prep is key. I take personal responsibility for this in my clinic. So I try to do my best in making sure that the kids are really, really, really clear just to make the scope portion go smoothly. So our testing protocol, our patients are held NPO and bed rest overnight post-catheter placement. They're just maintained on maintenance IV fluids. So we do next day testing. So we let our kids just kind of hang out on the floor with IV fluids overnight after the catheter is placed. In some studies that I found, you know, anesthetics can definitely alter colonic motility. And some patients eventually ended up having the patient stay overnight if they didn't kind of get the results that they were looking for after initiating the study within like 4 to 6 hours. So for our particular protocol, we keep kids until the following day. We test in 3 different phases at the bedside. So the first hour and a half is fasting. We then do a meal. It's about 20 kcals per kg, or in patients who are unable to tolerate oral feeds, we try to mimic like what a normal bolus feed would be like for them at home. Sometimes this gets a little bit challenging just because we have some patients who are only on TPN or get J feeds. And so we have to really kind of give families some reassurance. And of course, as long as it's deemed safe and appropriate, but that, you know, the patient may vomit and that's okay. We expect that to happen sometimes. But we really try to push patients to have as close to what would be a normal meal as possible for them. Again, trying to mimic as much as you can, sort of what they would be doing at home. We then do a 2-hour postprandial observation. We'll talk a little bit more about this, but that's typically because we want to see if we can elicit the gastrocolonic reflex, which generally happens about 2 hours postprandially. So we're giving us that window to see if we can assess for that. And then the final kind of what I call the meat and potatoes of the study is the bisicodal administration, which goes in through the lumen of the catheter. We do 0.2 milligrams per kilogram. And I tell patients that they're going to feel like they have the poop sweats and the bubble guts, to give them a realistic idea of what to expect. Again, I think having realistic expectations for everyone through this study is really important in making sure that you know, things go smoothly. So interpretation of the test is typically done visually. And this is helpful being at the bedside. You know, of course, once the study is complete, we go back and we review the data in its entirety. But it allows me, when I'm in the room, to have that kind of real-time feedback with parents to show them what's happening on the screen. And is this a response that I feel like is what we expect? Is it not? And, you know, sometimes we take things with a grain of salt. So I try not to overcall things if I see something that looks a little abnormal until, you know, we review it as a team, or I talk with my attending Dr. Jose Garza, you know, about what our plan is. So, but I at least try to give the families some indication of what I'm seeing and if it looks normal or not. So there are two major components to a normal study. First is the gastrocolonic reflex. So this is stimulated by neural and hormonal pathways. And this typically results in increased colonic activity within a few minutes of the start of the meal, up until about 2 hours postprandially. So sometimes you'll see like a nice low amplitude contraction occasionally, like in my patient last week had a high amplitude contraction following her meal, but you at least want to see some increase in colonic activity postprandially. And going into high amplitude contractions. So also you want to look for the presence of high amplitude propagating contractions that occur either spontaneously after a meal or in response to the bisicodal that propagate all the way to the rectosigmoid junction. Abnormalities in this part of the study, so when we're looking for those reflexes and we're looking for the high amplitude contraction, the absence can indicate some abnormalities in the enteric nervous system, but we'll go a little bit more into reviewing what the results ultimately show here. So an HAPC, or high amplitude propagating contraction, is really, this is like the hallmark of either normal colonic function or the potential to have normal colonic function. Pressure of at least 60 millimeters of mercury lasting 10 seconds and propagating for at least 30 centimeters. You do not see propagation into the rectum because the rectum is a reservoir. So it's a great, wonderful thing that you don't have propagation of those contractions into the rectum. So that's why you'll typically see kind of a area where the contraction stops, and then you have the anal sphincter that you can typically pick up on the catheter as well. That's below that. So this is kind of in a condensed form here, basically what you would see if you were to review the study it's in entirety. So you have your fasting phase where you may see some intermittent little blips of activity. Postprandially, you want to see that increase in colonic activity. And then with the bisicodal stimulation, you're trying to elicit those high amplitude propagating contractions. So key points during the study, we always have a nurse that's at the bedside. The responsibility of the nurse is to really place some notes in the computer, observe various patient behavior. A lot of times, unfortunately, we do have some either very odd familial situations or social situations, or the patient may have maybe getting a little bit of secondary gain from some of their symptoms and some of their medical complaints. So it's really important to have somebody that can kind of be there seeing these things and interacting. If testing is pointing towards functional constipation, take time to review this. It's much easier for families a lot of times to accept the abnormal, as odd as that is, than the normal, because normal kind of throws them for a little bit of a loop. So it's like, why am I so symptomatic, but all of my testing is normal? So given that I have the opportunity to spend a lot of time with patients in the room while the test is going, I try to do my best at really having that conversation. And then discuss the results of the bisacodyl as the study is going. So a lot of times we have patients, especially our younger patients, who are withholders. And so you can see that on the bisacodyl challenge, because you'll see at the level of the anal sphincter, they're squeezing like crazy in response to the high amplitude propagating contraction. So it's a way for you to give families objective data, like, we understand that this patient's having some pooping issues, but part of it is not because their colon isn't working, it's because over time they've had this withholding behavior that's contributing to their symptoms. Abnormal results, so you have partial propagation, minimal colonic activity, increased presence of HAPCs, which we don't see very often, but sometimes have seen in Hirschsprung's patients or post-op Hirschsprung's patients. And then even though squeezing at the anal sphincter is not technically abnormal, it's something to mention to the families along the way. So here's some visuals of abnormal. So you've got on the slide there to the left, absence of propagation. And this is what I see a lot, because we have patients who have quite distended rectosigmoid. And so what we see is there's that proximal propagation, but then you get to a certain point where the colon just kind of doesn't know what to do. So that's something that I actually see. That's probably the most, quote, abnormal result that I see. And then on the screen to the right there, you have minimal propagation, very little colonic activity. So where do we go from here? So if the study is normal, we optimize laxative therapy. Typically, we use stimulant laxatives. A lot of times our patients are having constipation and soiling, so we try to be careful about putting too many osmotic laxatives on the table there, just because we're trying to minimize the risk of accidents. If the patient is appropriate for pelvic floor rehab, then I think this can be helpful if they have constipation and dyssynergia that's seen on an anorectal manometry. I would deem a patient appropriate. So like an awkward, anxious 8-year-old, probably not the best candidate for pelvic floor rehab. But if you have a, say, teenage patient who is very vested in getting better, compliant with medications and regimens, then I think it can be really helpful. If there's poor propagation or weak contractions, then you consider a trial of high volume transanal enemas. We usually like to do this before recommending any sort of surgical intervention, such as a cecostomy, which sometimes does end up happening down the road, but we like to sort of do a proof of concept with the high volume enemas. Just one, to make sure that the family truly understands that it's an investment of time. So regardless of if it's going one way or the other, the process of administering the enemas still is very time consuming. And we also want to make sure that we're setting the patient up for success. So typically, if the transanal enemas are going really well, the patient would thrive potentially with a cecostomy tube. If the transanal enemas are going horribly wrong, or the patient's just having a really tough time, or they're withholding and having a lot of accidents, it gives you an idea that that may not be the best step. And then if minimal or absent colonic activity, especially with patients who have very dilated colon, we consider diverting ileostomy, and then potentially retest the colon in about a year. So this is Dr. Jose Garza, who I've been fortunate enough to work for since my start with the Motility team. And my personal pearls really is strong communication with your team. I mean, I think that's part of the reason why we've been really successful at CHOA is because we have a team that respects each other very much. And so I'm given a good amount of autonomy in what I do, but I think it didn't come overnight. So it's about earning respect and making sure that I'm constantly learning every day. And, taking each day, really making sure that we're optimizing patient outcome, making sure we're doing perfect tests. It's really nice. So let the plan be data driven. Very important, especially in these kids or patients who have had like $1 million workup, being, objective in their plan and maybe not always doing exactly what the family wants you to do, but really going for treatment off of those objective findings. Setting realistic expectations. I think I've said that several times through this. It's so key to be very upfront and open with families about what to expect for the test, what the potential outcomes could be, and really also, what do we do if this is normal? Because that's always the more difficult conversation to have. And then, of course, use your time wisely in explaining constipation, belly pain, which we see a lot, very often with our kids who are coming through and going through the various different types of medications, explaining them from a perspective that families can understand, osmotic versus stimulant is really important. So I think that being said, here's my references for just a list, or if anybody wants to do a little casual reading during the holidays.
Lisa, that was fantastic. Seriously, that was really well done. And I encourage all the attendees and future listeners to this on ANMS's YouTube station, implement this in their team's tutorials for new staff members to ongoing education. And if you're developing a program, this should be a bedrock to the development of your program. Really well done, Lisa. I'll start with one question. I was been blessed to do a lot of these over my years, but can you give some pearls of wisdom when removing the catheter at the end? Because patients kind of get used to it, or they get in a rhythm. They're on their iPad or phone or watching something on, or child health, they're playing games or something like that. But when it's time to come out, even though you set the expectations, type thing, just give us some wisdom about removing the catheter.
Sure. Fortunately, I found that while most patients are pretty nervous about it, they're so over being there that they're like, just get this thing out. And really, it's the tape that is the most bothersome thing. So I use hospital foam to loosen the tape. And then when I'm telling them when I'm going to take it out, I give them an idea. I kind of show with my hands about how long the tube is, because sometimes they don't realize how long it is and they get really nervous when they're like, oh my gosh, where was that? So giving them an idea of what to expect, like it takes just a few seconds. It's going to feel like, a giant wet spaghetti noodle coming out of your bottom. That's usually how I explain it. And then let them immediately get up to go to the bathroom, because it's usually right after the bisicotal and they're like begging to go to the toilet.
Thank you.
Mm-hmm.
Go ahead, Dr. Ambartsumyan, you want to ask the next question?
Yes, thank you. Thank you, Lisa. That was really great and wonderful. And I'm definitely going to have people who work with me as well to listen to this. Really well done. One of the questions that is posted here, it really discusses about the specifically of the protocol. And it's wondering between adults and pediatrics and between 1 day versus 2 day protocols. I think it comes down to doing the study same day or next day. Do you find it difficult keeping the catheter in for the extra day for majority of your patients?
That's a great question. And sometimes, especially, in peds, it does become a little bit challenging. I've actually found that most of the time, if I prep the patient well enough to know once this is in place, we're going to be posted up in the bed. So we got to find things to do. And this is just the way it is. So we make sure the catheter doesn't come out. But I really, it's surprising because sometimes in kids, even 4-year-olds who I'm like, oh man, this is not going to fly. They do pretty well. I think they're almost a little nervous to move around too much with it in place. And fortunately, and at least within my experience, we've not run into any issues where we're like, oh man, I wish we would have set this up sooner. There have been times, especially like if we're doing AD and colonic manometry, so like a dual study on a patient, where we'll actually start the data gathering the night before, just if we are concerned that from having both tubes in both ends, the patient's just going to have a really hard time tolerating that, then we will typically start. But even then, I would say it's like at least like 6 to 8 hours after the catheter placement.
Wonderful, thank you.
Probably get some response from both your expert opinions on this, but the next question is, why would you proceed to ACE if a patient is responding and tolerating transanal irrigation?
So the question is, why would you proceed with an ACE?
Yeah.
So actually the end goal is to not have to do that. So if we can get a patient that's tolerating transanal enemas, and especially I think also it depends on the degree of dysmotility they have and kind of what we think is long-term going to be working well for the patient. But we have plenty of patients who, even in the setting of knowing that they're potentially going to need to do these enemas for at least several years, if not a lifetime, often if the transanal enema doesn't bother them, we're all on board with them continuing to do that therapy versus going into an ACE. It's not to downplay the need for things like cicostomies, but we try to avoid it if possible.
Yes, I concur. In our center, and the studies show that in general, an antegrade continence enema, the whole point of it initially was to the independence. And with the new transanal irrigation systems, it actually do allow the patient to become independent. And thus, if a patient is able to independently do transanal irrigations and they're successful without having incontinence, then they don't need to necessarily proceed to an ACE. This is also a very interesting question, Lisa. And with regards to your center and how you guys do the procedures, do you do an abdominal X-ray prior to the start of the study, the second day?
We do. So at some point throughout the morning of the study going, we do a repeat abdominal X-ray. Yes, we do. Usually, thankfully, the catheters don't move too much, but it's helpful at least pinpointing, it would be terrible to go through the whole study and see something that looked very abnormal, but not have that objective view of where your catheter is at. So, we don't want to radiate our patients too much, but it's, I think, a really important objective part of the study.
Yeah,
And
I think the next question. Oh yeah, sure, yeah.
Just a quick follow-up to that question. Are there times where you would get the X-ray and then certain things you would see on the study where you felt like you needed to repeat it? Like, would you be able to identify coiling of the catheter or movement of the catheter that would necessitate repeating the X-ray?
So I think it would really just be based off of what I see on the screen. So we always have a patient cough too as we're starting the study. So you can see that good increase in intra-abdominal pressure. And just in experience and looking through it, usually if something looks really funky, then I try to do some other troubleshooting things, and it's technology, right? So sometimes you're going to have a wonky sensor that just doesn't want to cooperate with you. But if everything else looks fine, then I would probably continue on with the study. But usually it's just kind of making that clinical decision based off of what I see.
The next question is probably comments from both. It says, also for adults, why don't we do more colonic manometry before considering total or subtotal colectomy for slow transit? Is there any data on the plasticity of the colon in adult population as we have in kids?
That is actually an excellent question, and colonic manometry was in the past utilized in adults. It has fallen out of favor, especially in the more recent years. There are studies in adults on colonic manometry, and also adults having colectomies and cecostomies, as well as have appendicostomies and cecostomies. I thought that those have also fallen out of favor. The question about plasticity, that is actually an intriguing question. I'm not familiar with plasticity specifically as to the adults, but we know in pediatrics that if you have an abnormal segment of the colon, as on colonic manometry, and you divert the patient and or the patient has an appendicostomy, and you want to, let's say they're doing well and take out the appendicostomy, if you repeat the colonic manometry does improve pre and post ACE. And also there's data to support that the colonic manometry improves pre and post ostomy as well. So therefore, I do personally find that there is really important data to gain from the colonic manometry, and that would be even helpful for the adults as well if they have an ostomy instead of doing a colectomy, then to repeat the manometry if there's improvement to reconnect the colon.
Excellent. We're running near the end of time. I just want to ask Lisa one other question. First, I really thank both Lisa for constructing this presentation and giving it to everybody. It's really well done. It should be a cornerstone of everybody's practice. And Dr. Ambartsumyan being my co-moderator, and really appreciate your time tonight for this. But Lisa, for example, if a young Lisa walked into you and Jose's program, like what words of wisdom would you give her or him to, become someone like in your shoes, some years later, learning and getting involved and all that stuff that goes involved to where you're at now?
Sure. I think it would be, don't be too overwhelmed. It's a lot of material to learn, especially it's a very humbling experience too, to go from being a nurse on the floor where I felt like I was pretty seasoned and kind of knew GI to going into neurogastro and motility. So it was definitely a humbling experience, but I was fortunate to have Jose, as a mentor, and another colleague that I worked very closely with who helped train me. And I'm kind of forever indebted to them because they were very patient with me, but they were very big expectations. So I had to just jump right on in. So I think that neurogastro can be quite intimidating, but it's such a cool field because there's so much more to gain. So many times Jose and I are looking through studies and I'm like, I wonder if this affected that. And he's like, maybe it did. Maybe we should, maybe there's a research opportunity here. So I think that's the cool part of it. And especially having a good team to work with makes it all the much easier, much like most other positions.
Excellent.
Wonderful. And Lisa, I can't emphasize the importance and the role of having you, allied professionals at the bedside doing the procedure. I myself feel that the most important information is obtained by that person. Do you feel, with regards to your experience, that the history you get from the clinic, and then when you do the manometry, the information you get, what percentage of the time do you find that your clinic impression significantly changes just because you were there to observe the study?
Absolutely. I mean, I think really seeing the whole process through from beginning to end is so important. And sometimes we get it right, and sometimes we don't. And being able to have those conversations with families, this is what I think this may be, or I think this may be normal or abnormal, but then being able to really talk them through the study is helpful. And I was trained from the very technical side of things to tying the balloon on for anorectal manometries and calibrating the catheters all the way through doing some interpretation, the procedural side and interpretation. So I think that's helpful. And at one point, Jason had asked me, do you feel like how your clinic operates, is it helpful to have a nurse practitioner or a nurse? And I think that really just having that person that's there to have that consistency from beginning to end, like you said, Lusine, is really helpful. And it helps the families too, or the patient feel like they're being validated, and it's not just a new person each day coming through, giving them random tests. It feels a little bit more personal.
Wonderful.
Yeah, I couldn't agree with you more, Lisa. This is the whole world of neurogas and motility labs, having that partnership with the patient or parents and setting expectations and clear understanding of what's going on. I think this helps all these procedures just move much more fluidly than by having that, and having someone like you and you teaching other younger people coming along the way. The future is definitely bright. We had one question. I think we have enough time to ask one more question. Losing my screen here. It says, has anyone mentioned in PEDS particular, do you see a lot of patients with gastroparesis having colonic manometry?
I'll answer, and then Lusine, if you want to add your input too. Typically, if their complaint or if they have a complaint of gastroparesis or an underlying diagnosis, then we would do intraduodenal and colonic manometry coupled together. Usually, if it's just upper GI symptoms, sometimes we'll only focus in on that, whether it be esophageal or AD manometry. Typically, if those patients come with the other complaint of abdominal pain, then if we're already going to be doing an endoscopy and they're going to be under general anesthesia and they're needing to have AD manometry, then we will go forward with doing colonic manometry as well, just to cover all of our bases, because we don't want to have to then go back and do it. It's not a primary indication to do colonic manometry, but we do add that on for patients who are also getting AD.
Yes, thank you, Lisa. I concur. For us, if a patient comes in with primary colonic symptoms without any foregut symptoms, then we'll just do colonic manometry. But it is important, and this is where the clinic is critical, is finding out if that patient with primary constipation has any other symptoms. For example, if they have gastroparesis or a diagnosis of, then in that case, we would add an intraduodenal and in addition to the colonic.
Excellent. Well, we're near our time tonight. I'd like to thank both Lisa and Dr. Ambartsumyan for a wonderful presentation tonight. Any other questions that come in will be fielded over on Doc Matters. And we look forward to the next upcoming sessions for 2023, the Pearls of Wisdom series. And I wish everybody a good night.
Thank you.
Thank you very much. Thank you.